I want to talk a little bit about the recent data with the GLP-1s and the SGLT2s. I'm going to start with the GLP-1 class and remind you that it is highly heterogeneous. So we have the exendin-based molecules, exenatide and lixisenatide. We have the acylated human GLP-1s, liraglutide, semaglutide, and we have the macromolecular GLP-1s, dulaglutide and albiglutide. And we now have certainly the semaglutide and dulaglutide available as weekly formulations. And as you know, semaglutide also available in the US now as an oral formulation. So we start with quite different agents, and then we have 8 trials of the GLP-1s, which are all quite different. So if you look at the size of the study, so you have the very large trials, such as Excel, and then Rewind, which again in 10,000 patients. We have the small studies like Sustain 6 or Pioneer 6, which is the smallest trial of oral semaglutide. There are differences in the A1C inclusion. So when we made our initial consensus, all of the outcome studies had inclusion criteria of people with A1Cs above 6.5 or 7. So it's very difficult to make a recommendation that you should start independent of A1C. Whereas now, in Rewind, there was no lower limit. And in fact, many patients had A1Cs down to 5.5%, and the median A1C was only 7.2. Also, the inclusion criteria vary hugely. You have some studies in which all of the patients had established disease and were very high risk, like Elixir, where all patients had an acute event, contrasting with Rewind, where only about 30% of patients had established disease, although there is some subtlety to this, because a significant proportion here, the so-called subclinical group, were similar to patients that would have got into, for example, the LEADER trial. So this is not so straightforward. And at the time we did our update, and indeed still now, we don't have a breakdown for these 3 different subgroups. They're just either all lumped together or all lumped in this group as the people without disease. So if we look at the outcomes, we can see that there are some differences. So we have 4 studies that show a positive result, and 4, the one is not on here, Freedom, which has had a press release which showed it was neutral. That's the implantable exenatide. And this isn't simply, it may be due to a number of factors. It may be due to a definite difference between the GLP-1 agent itself, may be different in trial design, or it may be different in the cohorts of patients included. And if you look in Elixir, which was adequately powered and was a very high-risk group, there was really no impact on the MACE endpoint, although it was a 4-point MACE, but there was no impact on 3-point MACE. Whereas if you look in, for example, Sustain 6, which was actually an underpowered trial, there was a significant reduction in 3-point MACE. And there does seem to be some advantage of either the acylated or macromolecular GLP-1s in consistency in showing a reduction in 3-point MACE. In some of the studies, we see a reduction in cardiovascular death in LEADER. And in fact, although there's no p-value here because the study was small and underpowered, there was nearly a halving of cardiovascular death with the oral semaglutide. No impact on heart failure, apart from in Harmony, where there was a slight reduction in heart failure outcomes, but across the class, no impact. And as you see, in both Rewind and Sustain, some reduction in stroke. Rewind is important because if you look at the outcome by baseline cardiovascular disease, as you know, overall, this was a 12% reduction. There didn't appear to be a difference in people with a history of not or cardiovascular disease. Although if you look in prior events, and these are people with MI or stroke, although the p-value is not for interaction isn't significant, there is a greater reduction in those patients with MI or stroke compared to those without. So I think there's still some debate about the risk factor profile and how far we should open up the prevention with GLP-1s based on this evidence. In terms of kidney outcomes, the GLP-1s clearly have shown a reduction in proteinuria, and there was in Rewind a reduction in the composite kidney endpoint, but it was largely driven by, again, the impact on macroalbuminuria. And we've seen that also with Sustain and with Leader. So GLP-1s, reasonably good for the kidney. They're licensed to low eGFRs. They reduce proteinuria, but they don't have the same impact as the SGLT2s have. So just some comments about the SGLT2s, and I think we're learning all the time. So we know now from this meta-analysis, if you look at across the SGLT2s, across people with existing cardiovascular disease, we see this 14% reduction. There's a little bit of difference within the agents, but across the class it seems to be relatively consistent. But nothing, no harm, but no reduction in MACE in people without established cardiovascular disease. And that's where the evidence sits at the moment with the SGLT2s. However, when we come to heart failure, I think, as we've just heard in the previous session, a lot of excitement around the SGLT2 class, consistency as secondary outcomes in these big studies for reductions in heart failure. If we look across the class of glucose, of different classes of glucose-lowering therapies, we now have evidence to help us make very clear choices. We have benefit with the SGLT2s. We have safety and neutrality with the alpha-glucosidase inhibitors and the GLP-1s. We have heterogeneity in the DPP-4s, with some showing no signal and others showing an increase. And we have, we shouldn't use the TZDs, obviously, in this setting as they increase the risk of heart failure. We also have DAPA-HF, and in the brilliant talks just before me, you saw some of the data. And we know that in reduced ejection fraction heart failure, even in people without diabetes, we're seeing reductions in cardiovascular, in primary endpoints for heart failure in these patients. And there will be, I'm sure, a license change to support that. In terms of renal disease, we get reductions significantly in terms of dialysis, end-stage kidney disease, and reductions in acute kidney injury with the SGLT2. So I think very, very clear evidence now in terms of heart failure and chronic kidney disease. So what changes have we made? Well, the first thing we've said, which I think is a significant impact, is that we should be using these agents independent of baseline A1C or individualized targets. So we shouldn't wait for the A1C to be out of control. We should be adding GLP-1s or SGLT2s to reduce MACE, heart failure, or chronic kidney disease progression, regardless of the baseline A1C. In terms of the early combination, we didn't feel on the basis of one study we could change that, but there may be shared decision-making around early combination use, and we already advocate it in people more than 1.5% above target. What about the GLP-1s? Now, as I think I've shown you, or hopefully convinced you, the data for MACE appears to be stronger for the GLP-1s than it is for the SGLT2s. And so where the level of MACE is the greatest threat, then they are probably preferred for that reason, although there may be other reasons around costs and injectable therapy why you may choose differently. But in terms of MACE, that's where the GLP-1s have the strongest data. And also, we've now suggested that they should be considered in people without established disease, but with high-risk indicators. And it's difficult because in the previous talk, I think they talked about younger type 2, and I am very passionate about aggressively treating young type 2. In all of these studies, less than 1% of patients were under the age of 40. So, and many of those patients were excluded from these trials. But now we should consider high-risk indicators for also their use. The SGLT2s in people with or without established atherosclerotic disease, but with particularly reduced ejection fraction, heart failure, or chronic kidney disease. And we talk about an albumin-creatinine ratio of greater than 30, but particularly greater than 300. We have very good evidence now for the benefit of the SGLT2s, particularly with Credence and others. So we are recommending their use in those groups of patients. The foot ulcer story, we need to be careful about shared decision making. In Credence, where there was good surveillance of those patients, then we didn't see the increased risk of amputation. So this is how the algorithm looks now. It talks about those high-risk indicators. It talks about heart failure. And right at the top then, it talks about adding independent of A1C and the preference for the GLP-1s for MACE, but you can obviously still use an SGLT2, and the clear preference for the SGLT2s in the setting of heart failure or chronic kidney disease. Thank you for your attention.